The Schilling test is an older but elegant assessment of vitamin B12 absorption. It evaluates whether inadequate B12 levels are due to dietary deficiency or insufficiency, intrinsic factor deficiency, as seen in pernicious anemia, for instance, or malabsorption. Although this test is no longer commonly used and it is not within the scope of an ND, understanding its mechanism can help us interpret B12 labs today and understand how intrinsic factor plays its role. This slide visually demonstrates the process you just kind of heard described. This test uses radio-labeled B12 and tracks how much appears in urine. The key idea is that when intrinsic factor or the ileum function is impaired, absorption drops dramatically. Remember that intrinsic factor is required for B12 absorption in the terminal ileum. In step one, the patient swallows a radio-labeled B12. Then an intramuscular injection of regular B12 is given to saturate the body's receptors. Any radio-labeled B12 that is absorbed will then go straight into the urine. In normal physiology, 8 to 40% of the radio-labeled dose should be excreted in the urine over 24 hours. In pernicious anemia or other malabsorption disorders, very little will show up in the urine, indicating low absorption. If low excretion is detected in step one, we repeat the test, this time giving intrinsic factor with the oral radio-labeled B12. If urine levels normalize, the diagnosis is pernicious anemia, meaning intrinsic factor deficiency was the problem. If levels do not normalize, malabsorption at the terminal ileum becomes more likely, and this is an elegant example of functional diagnostic sequencing. And this is kind of showing the principles of the Schilling test and looking at kind of these sequential versions of the Schilling test. You could think of it like troubleshooting. If B12 doesn't show up in the urine after oral dosing, we systematically add intrinsic factor, antibiotics, or pancreatic enzymes, depending on the suspected cause. And this test we consider as more elegant because it didn't just tell us that malabsorption was happening, it actually helped us determine why. If adding intrinsic factor does not correct the problem, the next step to consider bacterial overgrowth. In this step, the patient takes antibiotics for approximately 1 week and then repeats the test. If bacterial overgrowth was the cause, meaning bacteria were coming or consuming B12 before the body could absorb it, urinary excretion will normalize after the antibiotics. If the results still do not normalize, we move to the next test. The final variant adds pancreatic enzymes to the mix with the oral radio-labeled B12, and pancreatic enzymes are necessary to free B12 from dietary proteins before intrinsic factor can bind to it. If urinary levels rise only when pancreatic enzymes are given, this suggests pancreatic insufficiency is the dominant problem. Notice how this test strategically rules in and rules out causes of B12 malabsorption, intrinsic factor deficiency, bacterial overgrowth, or even pancreatic insufficiency. And this table shows how the different conditions present across the steps in the Schilling test. For example, pernicious anemia here up top shows normal B12 excretion only after intrinsic factor is added. So that's the only time it sees normal. Versus chronic pancreatitis, seen here, will show normal with pancreatic enzymes, for instance. SIBO or bacterial overgrowth, normal after antibiotics. This visual is really helpful for board studying and actually to help with as an interpretation guide of what these conditions are lacking. Today, though, despite spending all this time talking about it and talking about its elegance and its helpfulness, we rarely actually use the Schilling test because we can diagnose intrinsic factor deficiency with a simple blood test, intrinsic factor blocking antibodies. And the modern approach is you check B12. If the levels are low, you check methylmalonyl acid. If MMA is elevated, that confirms a cellular deficiency. Then we test for intrinsic factor blocking antibodies to diagnose pernicious anemia. This approach is much simpler, less invasive, and doesn't involve any radioactive tracers. So this will show us kind of the modern or more modern replacement approach. First, we start with testing B12, and I know it's really tiny. If we're below 300, if we're not above 300, we're considered normal, so we would stop. If we're below 300, we would test for MMA, methylmalonyl acid. And then if we're looking at methylmalonyl acid being elevated, then you would test for intrinsic factor blocking antibody. And if that was positive, you would have pernicious anemia as your diagnosis. If it was negative, then you would look at parietal cell antibodies as your test. Positive, that's pernicious anemia. Negative, you would test gastrin. And then from here, if gastrin is elevated, then pernicious anemia. It's an indirect confirmation. So these are all kind of steps that could get us to that pernicious anemia diagnosis. We'll stop here. When we come back, we'll talk about H. pylori.